So these are the areas, topics given to me. Some of these you may be very familiar with the definition, like definitions of important terms. You are familiar with as part of the NVBDCP program. And I will also touch upon the high-risk groups and the transmission dynamics. Coming to the definitions, I think in 2009, WHO, they revised a dengue case classification to classify the dengue infection based on the levels of severity. So as per WHO, we are supposed to classify dengue infection as severe dengue we have, and then in the dengue with warning signs and without warning signs. And in the, you can see below, like they have mentioned, like what are the warning signs. And there are definitions like definition, WHO definition on, like you can see below, like probable dengue and what is laboratory confirmed dengue. The probable dengue, they have given definition like living in or to travel to a dengue endemic area, and then fever with any of the two following symptoms, that is considered as a probable dengue. And then the laboratory confirmed dengue, WHO has defined like doing a IgM or NS1 or PCR, that is considered as laboratory confirmed dengue. And then this based on classifying dengue based on severity, like with warning sign and without warning sign. Like they have listed what are the warning signs, like abdominal pain, vomiting, fluid accumulation, mucosal bleed, liver enlargement, and then the laboratory. So these are, they have listed as warning sign. If a dengue case has any of these symptoms, it's called as dengue with warning sign. If they don't have any of this listed warning sign, then it is classified as dengue without warning sign. So these cases can they can develop severe dengue, and severe dengue is those who have plasma leakage, hemorrhage, or severe organ impairment, like the dengue shock syndrome or dengue hemorrhagic fever. They are considered as severe dengue, like DSS, dengue shock, as well as fluid accumulation and severe bleeding and severe organ involvement, involvement of liver or CNS or any other organ. So this is the 2009 WHO classification of dengue infection based on severity. IDSP, they were again defined, like they have given definition for dengue fever. I will just quickly go through because I know you may be very familiar with all this definition. IDSP definition on dengue fever. We have clinical case definition like acute febrile illness, 2 to 7 days, no, with two or more of the following. Any fever with 2 to 7 days of duration, and they should have any of the two or more of the following symptoms of headache, retroorbital pain or myalgia, body pain, arthralgia, joint pains, any rash or hemorrhagic manifestation or leukopenia. So if they have any of these two symptoms with fever, then it's a dengue fever. And then probable. So in an area, the medical officer is diagnosing as a dengue fever based on the clinical definition. And then even if I think I took this definition from the IDSP website, I think if there are any updation, you can highlight. And then it should be supported by serology. Serology, I think here they have given us hemagglutination inhibition, antibody titer or IgG. I think now routinely it is adopted on is IgM and NS1 antibodies, NS1 antigen or IgM antibody test. IgM usually after 5 days, and before 5 days we test for NS1. Or an epidemiological link with a confirmed case or area with high vector density. So these are probable. And this is the IDSP definition for confirmed dengue fever. Isolation of dengue virus from like serum or plasma or autopsy samples, or any fourfold rise in titers. Like if we have paired specimen, usually in dengue, what we call it as acute samples and convalescent samples. What is acute sample is within 5 to 7 days. If you collect the blood sample, then it is called acute sample. After collecting the first sample, after 7 to 14 days after the first sample, if you collect, then that is called convalescent sample. So 2 samples we collect. One is in the acute stage, that is within 5 days of fever onset, and the other one is the convalescent sample, 7 to 14 days after the first sample collection. If we have this kind of paired samples, then we can look for rise in antibody titers. So if we can demonstrate 4-fold rise in antibody titers, then that is also like a confirmation of dengue fever. We can also like isolate dengue virus antigen. We can do PCR of all the samples for confirmation of dengue. And then for dengue hemorrhagic fever, it's defined as probable or confirmed case of dengue fever with one or more criteria of like they should have a positive tonic test or red color petechia or rashes or any bleeding from mouth or nose or intestines, any bleeding, and then thrombocytopenia, platelet plus low platelet count, and then evidence of plasma leakage like having a pleural effusion, fluid accumulation around the lungs, or in the fluid accumulation in the abdomen, or low protein, hypoproteinemia. So these are the definition for dengue hemorrhagic fever. And then we have a definition for dengue shock syndrome. A case of dengue hemorrhagic fever, if they have evidence of circulatory failure, like this is the most important, like pulse pressure, like the difference between the systolic and diastolic pressure, that is the pulse pressure. If it is less than 20 millimeter of mercury, or having a weak pulse, hypotension, low BP, so this is these are all signs of like dengue shock syndrome. So these are the definitions given in the IDSP website for dengue. Coming to the risk factors, who are at a higher risk of dengue infection? First important risk I think we have seen on the earlier presentation is living in an endemic area. That is the important risk factors. If a person living in South Asia region, India, a person living in South America, or traveling to South America, or traveling to Asia, India, so they are at high risk of occurring dengue infection. And all ages are at almost they are at risk of getting dengue infection. All ages and both genders. There are no difference between male and female. So having said that, all ages at risk of infection, dengue is usually considered as a pediatric disease. It's mainly affecting the children. So you may see a higher incidence of dengue in children. So I think it's similar to the earlier slide on burden of disease across the world. Like you can see that based on the Aedes vector presence, they have mapped the environmental suitability of dengue, where the Aedes vectors are abundant. You can see in the South American countries, Central African countries, and then the Southeast Asian countries, where the vector is abundant. Aedes aegypti and Aedes albopictus vectors are abundant. So it's on the temperature and other climate indicators also found to be suitable. So these are the countries at risk of dengue infection. So coming to India, I think by geography, here I think Dr. Manoj, he raised a valid question like whether NI is involved in NI is contributing to the vector-borne disease control program. I think this is one of the major contributions in the recent years from National Institute of Epidemiology. We did a dengue serological survey. So we did the dengue sero survey in 15 states. So for the purpose of this study, we divided the country into 5 geographic regions. You can see that like southern region in blue color, and then western region, north region, and then east, northeast. So we divided the country into 5 regions, and each region we selected 3 states. In each we selected 3 states, And in each state, we selected 4 districts. In each district, we selected 4 clusters, 2 from rural areas and 2 from urban areas. We collected samples by dividing the participants into 3 age groups, 5 to 8, 9 to 17, and 18 to 45. So we divided them into 3 age groups, 5 to 8, 9 to 17, and 18 to 45 years age group. So we did this survey in 2017. The survey findings are published in Lancet Global Health. I have given the link to the paper at the end of the slide. So what are the key findings from the serosurvey? So I think now everybody is familiar with the serosurvey because COVID, because of to track the COVID-19 pandemic, all the states, even at the national level, we are involved in serosurveys. So even before that, we did a national level serosurvey. We collected 12,300 samples across India, and we estimated the sero prevalence. So can someone describe this slide, like where the sero prevalence is high, which region and which age group? Is it can you see the slide? I think someone can see in which region do you think the sero prevalence is high? Where it is high? So in the x-axis, we have given 5 geographic regions: north, east, west, south, and northeast. I think one of you can volunteer and describe this chart, where the sero prevalence, which region has the highest high sero prevalence. So I think you can see that the sero prevalence was high in the
south,
south region, and then followed by like west,
followed by
north, north region. So these 3 regions, they have very high sero prevalence. For this survey, we included the east into the Odisha in the east region. In the east region, we did the 3 surveys. 3 states we included. One is Odisha, West Bengal, and I think the Bihar was also included in the eastern region for the purpose of this survey. State-wise, we have given the sero prevalence by age group in the supplementary appendix. If you go to the end of this paper, there is a supplementary appendix. In the appendix, we have given the sero prevalence by state and by age group. So for Odisha state also, you will be able to find the sero prevalence. So one of the key findings from the study is the sero prevalence was very low in the which regions? It was lowest in the sero prevalence was lowest in which region?
northeast.
Yeah, northeast. Northeast region, I think the sero prevalence was, we found it very low. Also, the eastern region also had a low sero prevalence. That means they are still in the early stages of this dengue epidemics. So large number of population is still susceptible to dengue in people living in Bihar or Odisha or Chhattisgarh. So these regions, eastern regions, there maybe the sero prevalence is low. Still large number of people, they are still susceptible. So in future, the dengue outbreaks, it can become more frequent in these areas. Already you can see in northeast, although the vector is abundant, the dengue outbreaks are very recent. It's restricted to all urban, big urban areas like Guwahati. Big urban areas still now they started reporting cases. In future, it may increase because of huge population is susceptible to dengue outbreak. And one of the reasons why we did this study is in 2017, I think there was one vaccine approved by WHO that is called Dengue vaccine. Many countries are using this Dengue vaccine, like Singapore or even US FDA has approved. Initially, the WHO has recommended that only the countries or states with regions with more very high seroprevalence only, they should introduce the dengue vaccine. They only should introduce the dengue vaccine because dengue vaccine, the dengue vaccine developed by Sanofi, it can be given only to the seropositive individual. It cannot be given to a seronegative individual. If it is given to a seronegative individual, then if they again get it after the vaccination, if they get a dengue, the first infection itself will be like a severe infection. So that's why now the current WHO recommendation is you have to test the individuals for IgG antibodies. If they are IgG positive, then you have to give the dengue vaccine. If you are IgG negative, then you are not supposed to get the dengue vaccine. So based on the test and vaccinate strategy, Singapore is giving the dengue vaccine. Even US FDA has also approved for maybe Americans traveling to endemic areas. They can test for IgG antibody. If they are positive, then they can get the dengue vaccine. So US FDA has approved. WHO has also approved a test and vaccinate strategy. So even before this test and vaccinate, when the WHO recommended the dengue vaccine based on seroprevalence, so that's why we did this study. After the study, the WHO has changed the recommendation to test and vaccinate. Still, I think the study was useful to give a picture of what is the seroprevalence or exposure to dengue across different geographic regions in India. So we also modeled the age-wise seroprevalence by age. So these are called age-specific seroprevalence curves. I think in the previous slide also, what do you see across all the three regions? We know that south and west and north, they are having a very high seroprevalence. By age, what do you see? By age, what is the seroprevalence? For example, you take the south. In south region, by age, what is how the seroprevalence is? In which age group it is low and which age group it is high?
18 to 45 high.
Yeah, very good. Where it is low?
5 to 8 years are very low, and 8 to 45 years are high risk.
So what we say is, as you can see clearly in this next page, clearly in the next page, the seroprevalence curves. The seroprevalent curve, you can see that as the x-axis is the age and y-axis is the seroprevalence. You can see in all regions, like except this northeast or something. As age increases, the seroprevalence increases. So why does that happen? So what does it mean? Like as age increases, the seroprevalence increases means what does it mean? So why the dengue pattern why it is low in the 5 to 8 and why it is high in the 18 to 45?
18 to 45 is the working group and they get maximum exposure to mosquito bite, vector bite.
Yeah, thank you, ma'am. I think the elder, as you grow, no, you are it's like cumulative exposure because children, they are newly born and children are still very young. But people who are old means they are exposed for long period. No, it's years of exposure. They are exposed for a very long period. So it is likely that they all their exposure is very high. That's why the seroprevalence is more. Children, the number of years they have lived here is very less number of years. Their exposure is very less. That's why the seroprevalence is low. So as age increases, the seroprevalence increases. It means that the disease is endemic. If a disease is endemic, then as age increases, the seroprevalence is increased. But whereas in case of epidemic transmission, if you have seen the 4th national serosurvey for COVID, you will see that the seroprevalence is same across all age groups. Even children also having the same exposure, even adults also having the same exposure. That means in an outbreak where everybody is not, all of them are not having immunity for COVID. All of us, whether it's children or adult, all of us are not having immunity for COVID. So when a new virus comes, where nobody has immunity, then all of them will be affected equally. That is why the COVID seroprevalence, if you see, it will be the same in all age groups, because the transmission is epidemic transmission. It's an outbreak transmission. In outbreak transmission, we see the attack rate and seroprevalence is same in all age groups. Whereas if it is endemic, the younger age group will be having lower seroprevalence and older age group will be having higher seroprevalence. So that's what we see in the by age group. As age increases, seroprevalence increases. It means that the disease is endemic. The transmission is endemic. Coming to the rural and urban, so what's your observation on the rural urban difference, seroprevalence? Where it is high? Urban, yeah. Across all regions, you can see the seroprevalence is higher in the urban area. Even I think in Odisha, you will see like the dengue outbreaks are more in urban areas compared to rural areas. But whereas across all regions, you can see, but something like in the southern region, you see, even the south seroprevalence and the rural area seroprevalence is also very high. For example, in states like Tamil Nadu, dengue is not restricted to urban areas. It's also common in rural areas now. Rural areas and as you mentioned in semi-urban areas. Urban and semi-urban areas, now the dengue might be more in Odisha. But in future, I think you will see that it will slowly spread to even rural areas. Because rural urban migration is happening, even rural areas because of water shortage, people store water and they use one-use plastic. So all this rainwater gets collected and mosquito with virus becomes abundant. You see the transmission in rural areas as well. So gradually, I think the epidemic will move to rural areas as well. I think this is one example, one important risk factor. As before coming to ICMR, I worked as a health officer in Coimbatore city. As a health officer, I was like in charge of dengue control in Coimbatore Corporation. So one of the problem we often face is the water supply in urban areas. Usually in Coimbatore, in urban area, people they get water once in 20 days, once in 15 days, once in 20 days they get drinking water. So what they do is people they store in big drums. They stored in drums. What happened? This storage becomes they often they don't close those big barrels, and leading to a lot of breeding of Aedes mosquitoes in those areas, leading to a large number of dengue cases. So, like water supply, I think increasingly we feel that it is it's playing a major role in transmission of dengue. If the water supply is regular, if the water supply is water is supplied daily, then people will not store the water. So there won't be any, the breeding will be less and the dengue transmission will be low. But if the water supply is like the frequency is, if the water supply is increasing to once in 15 days or 20 days, then obviously people they have to store for 20 days in large drums. And it will be a very good potential source of breeding of Aedes. Often they don't cover those drums. So it's very difficult to control. Even if you go for anti-larval measures, people will not cooperate because water is very precious for them. They get once in 20 days. They will not allow you to empty the barrels because of breeding of larvae. They will not even allow you to apply temifos or some other anti-larvicide. So these are some of the challenges. I think now increasingly in states like Tamil Nadu, the water supply is playing a major role. So this study in Vietnam, they looked at the water supply and areas with water supply and areas with well water. You can see that wherever they used the tap water, the incidence, the attack rate was very low. Wherever there is no tap water, the incidence is, they found it's very high in areas where there are no tap water. So another important, like from the global burden of disease study by age. By age, what do you see, like by age, incidence, DALI, all this mortality? So what do you see at the global incidence of dengue by age in the first figure? In the first figure, we are talking about the global incidence of dengue by age. So in which age it is high or which age it peaks? The first one on incidence of dengue.
10 to 15 years.
Yeah, I think that's a very important thing, because most, if you look at by looking at the seroprevalence, you saw like even more than 50% are exposed before they are 5 or 8 years, 5 to 8 years. More than 50% of them are exposed in endemic areas. So by 10 years, most children will be exposed to primary infection. So then the secondary infection will be most likely in the second decade, 10 to 20 years. So likely to be more severe or symptomatic. Secondary infections are very common in second decade of life. You can see that the incidence is very high in the 10 to 14 or the second decade. You can see it is increasing. After that, it is plateauing. So it is not declining further. It's the same. After, you can say after 40 years, no, it's the same incidence across different age groups. Coming to the DALI rate, the DALI is disability adjusted life year lost is very high among children, because dengue is primarily a pediatric disease. So children, the death is also very common among children. And the third one, you can see that the mortality rate, where the mortality is high, mortality rate, third one. Mortality rate is high in the extremes of age. Both children as well as elderly, both are at higher risk of death, because they cannot tolerate this fluid imbalance, because in dengue shock, or if there is a plasma leakage or a hemorrhage, they will not be able to tolerate. That's why the mortality is in the extreme ages, it's very high. Still in the adults also, young adults also, we see deaths, but the death rate is high among the young children as well as the elderly across the board. I think the same as the population density and the incidence by age. The incidence by age is on the less than 5 years, they say 5 to 15 years, less than 5 years, the peak is less, and 5 to 15 years, you can see the peak is high, the higher incidence in 5 to 15 years. By gender, I think overall there is not much difference. I think you have seen in the I don't know whether I have shown the seroprevalence in India. This is a global burden of disease study. I think there is not much difference between male and female, because we know that it doesn't differentiate, the mosquito doesn't differentiate it's a male or female. You can see that our seroprevalence study, what do you see? The seroprevalence by age, you have seen a huge difference. Young age, low seroprevalence, older age, higher seroprevalence. Whereas in the gender, what do you see the seroprevalence? By male and female, the dengue seroprevalence, is it same or different? In all the regions, I think we have given the seroprevalence by region and by sex, male or female. So is it same or different? I think it is the same. So both on male, by male or female, there is no difference in the seroprevalence. Both are exposed. And then we know that there are some risk factors for severe dengue infections, like severe secondary dengue, young children, people with comorbidities like obesity or hypertension, asthma. So these are some of the risk factors for severe dengue infection. And then coming to a bit of transmission dynamics, because I was supposed to cover in this presentation about the transmission dynamics. I think it's a little complicated one. I'll try to simplify. I think the entire population, we can group them as into these three categories. Either they are susceptible, or they are infected, or they are recovered. So this is called SIR. Either an individual is susceptible to infection, or already infected, or after infected they are recovered. So these are the three. We can put the people, our people, into three compartments: susceptible, infected, or recovered. What is the problem? This kind of model you foresee in dengue. Okay, a person is susceptible, and then after that they are infected. After that, can we say that they will never get an infection in dengue? A person is infected with dengue, and he was susceptible earlier and got infected. After that, after recovery, can he be susceptible again? Yes, I think Dr. Baldev has said yes, they can be susceptible because we have 4 serotypes in dengue. So once they are susceptible, the susceptible person getting infected with one serotype, then he again becomes susceptible because he can get infection from the second serotype. So till they are getting infected from all the 4 serotypes, yeah, once they are getting infected with one serotype, they will get immunity lifelong for that particular serotype, but they can get infected by other serotypes. So that's why this model, standard model, may not be applicable for dengue. After susceptible, infected, recovered, again they become susceptible because they can be infected with other serotype. So these are called SIR models. Yeah, I agree with Dr. Ashit that the infection, cross infection or infection with other serotype, that makes it more severe. That is why secondary infection is becoming very severe. Secondary infection is very severe because they are getting infected with a different serotype. That makes it more dangerous. So in this SIR model, there is a, like, we can calculate what we call as force of infection. The force of infection is nothing but a rate at which the susceptible individual become infected. I think it's a very complicated formula. Better I skip this. Like, we have susceptible and the next box is infected. So what is the rate at which the susceptible become infected is called the force of infection. What we can do is like the force of infection is called the rate at which susceptible individual become infected. What is the risk of, like, what is the annual risk of an individual who is susceptible becoming infected? That is called force of infection, or lambda. So in the same study using seroprevalence data, we have estimated the force of infection for different geographic region. You can see that force of infection was higher in the southern region and lowest in the northeast region. For example, you take the southern region 5 to 45 years, the value is 0.08. That is 8% of the population, they convert from negative to positive, that is seronegative to seropositive. They convert every year. Using this force of infection, what we can do is we can estimate the burden of infection in India. That's what earlier in the slide I have showed how much is the burden of infection in India in 2017. And another important using seroprevalence data is SP9. In the last column, we have given SP9. What is SP9 is seroprevalence at the age of 9 years. At the age of 9 years, you can see that by the time they become 9 years old, the seroprevalence is 55% in southern region or 53% in the northern region. That means by 9 years of age, half of the children, they are already infected. They already become seropositive. But what WHO recommends for dengue vaccine is at least this SP9 should be more than 80 to 90%. Then only we can introduce the dengue vaccine. So the SP9 they have used as an indicator for introducing the dengue vaccine without the test and vaccinate strategy.